Hi, welcome to Dental Board. A very warm welcome to all the doctors and soon to be licensed doctors joining us today. You are watching part 17 of our General Dentist Prometric Exam High Yield MCQ series. If you missed any previous parts, you can check out the complete playlist linked right up here in the card or in the description below. Before we dive into these essential exam questions, make sure to hit that subscribe button and click the notification bell so you never miss an episode. So let's get right into the video. Alright, starting off with question number 1. Which of the following has a high recurrence rate? A. Residual cyst. B. Cyst. C. Odontoma. D. OKC. The correct answer is D. OKC. So let's look at a quick breakdown of why D is the right choice. Odontogenic keratocyst or OKC takes the top spot for high recurrence because of its thin, fragile epithelial lining, aggressive growth pattern, and sneaky daughter or satellite cyst left behind in the bone. It is notoriously hard to eradicate completely. And let's quickly check why the other options don't fit. A residual cyst is just a leftover radicular cyst. It has a low recurrence once fully enucleated. Then our option B, cyst is way too general and not a specific high-risk lesion. And odontoma is a benign, tooth-like growth that almost never recurs after simple removal. So now let's move on to our next question. At the beginning of the operational day, the dentist should run the air water spray or flush the dental unit water lines for 3 minutes to prevent contamination by which microorganisms? A. Pseudomonas aeruginosa. B. Streptococcus sanguis. C. Streptococcus mutans. D. None of the above. The correct answer is A. Pseudomonas aeruginosa. And here's why. Overnight stagnation in dental unit water lines creates the absolute perfect environment for opportunistic pathogens to form biofilms. Running or flushing the air water spray for 2 to 3 minutes at the start of the day helps to clear out these accumulated microbes, most notably Pseudomonas aeruginosa and Legionella, to prevent cross-contamination and protect our patients. Streptococcus sanguis and Streptococcus mutans are normal oral cavity bacteria associated with plaque and caries, not waterline biofilm contaminants. So let's move on to our next question. A patient comes to the dentist complaining of gum bleeding. The examination reveals lost gum stippling, areas of swelling that easily bleed, pocket depths of 4 to 6 millimeters, and no loss of attachment level. What is the most probable diagnosis? A. Acute gingivitis. B. Chronic gingivitis. C. Medication-induced gingival enlargement. D. ANAC. The correct answer is B. Chronic gingivitis. The definitive key here is no loss of attachment level. Even with 4 to 6 millimeter pocket depth, these are pseudo pockets caused by tissue swelling rather than true periodontal breakdown. Classic signs like loss of stippling, bleeding on probing, and localized swelling confirm active gingival inflammation because ANAC presents with a distinct, painful, punched out papillae and pseudomembranes, and acute gingivitis has a sudden localized onset. This presentation, typical of long-standing plaque accumulation, clearly points to chronic gingivitis. So let's move on to our next question. A patient comes in complaining of pain when biting on his molar that has an amalgam restoration. Cold test results are normal. The patient mentions that the restoration has felt high since it was placed. The tooth is tender to touch. What is the management? A. Remove interference. B. RCT. C. Remove restoration and put a temporary filling. D. None of the above. The correct management here is A. Remove interference. So let's break down why. The patient's pain occurs specifically on biting. The tooth is tender to touch and the cold test is completely normal. This tells us the pulp is healthy and white, but the periodontium is inflamed due to occlusal trauma caused by a high restoration. Since there is no irreversible pulpitis or necrosis, jumping to a root canal treatment or removing the entire filling is unnecessary. Simply checking with articulating paper and adjusting that high spot will relieve the pressure and resolve the symptoms. So always go conservative when the pulp is vital. And let's move on to our next question. A patient has received a blow to the right side of his face. He has a horizontal mid-root fracture. There is no response to the pulp test and there is a gap between the two segments. The tooth is symptomatic. What is the management? A. Institute RCT. B. Extract apical part. C. Extract both parts. D. Leave it. So the correct management is C. Extract both parts. While horizontal mid-root fractures can sometimes be stabilized with a splint if well aligned, this case has critical warning signs: a separation gap between segments, no pulp response, and active symptoms. The presence of a gap combined with pulp necrosis in a symptomatic tooth means bacteria have invaded the fracture site. Because a predictable endodontic seal across a displaced mid-root fracture is nearly impossible and the prognosis is hopeless. Extracting both the coronal and apical segments is necessary to eliminate infection and allow proper healing. A tricky trauma case, but critical to remember. Let's move on to our next question. What is the advantage of zinc polycarboxylate cement over zinc phosphate? A. Compressive strength. B. Thinner layer. C. Biocompatibility. D. Solubility. The correct answer is C. Biocompatibility. While zinc phosphate is well known for its high compressive strength, it uses phosphoric acid, which has a very low initial pH of around 1.6 to 2. That low pH can cause postoperative pulpal irritation. In contrast, zinc polycarboxylate uses polyacrylic acid. Because polyacrylic acid molecules are much larger polymer chains, they cannot penetrate dentinal tubules easily. This makes zinc polycarboxylate significantly more biocompatible and much gentler on the dental pulp. So let's move on to our next question. A proxy brush is used for which embouchure type? A. Embouchure type 1, B. Type 2, C. Type 3, and D. Embouchure type 4. The correct answer is B. Embouchure type 2. So, embouchure spaces dictate our interdental cleaning choices. The type 1 is the interdental papilla fills the space completely, so we use regular dental floss. For type 2, moderate papilla recession occurs, creating a wider triangular gap. An interdental brush or proxy brush fits comfortably here to clean concave root surfaces. And for type 3, complete loss of the papilla creates an open space where larger single tufted brushes or specialized tools are required. So remember, proxy brushes are ideal for type 2 embouchures. Let's move on to our next question. What is the most common acute injury during dental floss use? A. Recession. B. Laceration of interdental papilla. C. Loss of attachment in lingual sulcus. D. None of the above. The correct answer is B. Laceration of interdental papilla. When patients use improper technique, typically snapping or pulling dental floss straight down with too much force past the contact point, instead of gently sewing and curving it around the tooth, the floss cuts directly into the soft tissue. This sudden mechanical trauma causes an acute laceration of the interdental papilla. Gingival recession and loss of attachment are chronic long-term conditions resulting from persistent trauma or disease, whereas a laceration is an immediate acute injury. So educating patients on flossing technique saves tissues. Let's move on to our next question. How do you calculate lateral condylar guidance using Hanau's formula? A. L equals h by 8 times 11. B. L equals h by 8 plus 12. L equals h plus 8 by 12. D. L equals h plus 12 by 8. The correct answer is B. L equal h by 8 plus 12, where L equal lateral condylar guidance and h equal horizontal condylar guidance. So, Hanau's formula is a classic empirical equation used to calculate the lateral condylar guidance angle on semi-adjustable articulators when only the horizontal condylar guidance is recorded from a protrusive cheek bite. Dividing h by 8 and adding 12 gives a practical approximation of the lateral condylar path inclination, ensuring a proper eccentric articulation setup. Definitely log this formula in your memory for board exams. Divide your horizontal angle by 8 and then add 12. Now we are on to our final question for today. A patient comes to you after trauma. He has lost some epithelium layers and has intense pain. His upper central incisors got intruded. What is the most probable diagnosis? A. Concussion. B. Laceration and luxation. C. Subluxation. D. None of the above. The correct answer is B. Laceration and luxation. So the patient presents after trauma with central incisors that are intruded, meaning pushed axially into the bone. This specific displacement is classified under luxation injuries. Additionally, the patient has intense pain and lost epithelium layers, indicating a soft tissue injury, specifically a laceration. So when we combine the axial displacement of the teeth, that is luxation or intrusion, with the tearing of the soft tissue, that is laceration, the most accurate and inclusive diagnosis from our options is laceration and luxation. Concussion and subluxation are minor luxation injuries without displacement. So that's wrap up part 17 of our high yield MCQ series. And if you found this section helpful, give this video a big thumbs up, share it with your colleagues who are studying, and don't forget to subscribe to the channel for the next part of this series. Keep up the hard work, stay consistent, and I will see you all in the next video. Good luck with your preparation. Thank you.